Good afternoon, dear friends, and I would like to thank Gaurav for inviting me to this course. I'll just present a case which I did last week. This was a 3-month-old infant, torch positive, who came with bilateral dense cataracts, which I had to manage. So it is challenging to operate on an infant. So this is how it presented. You can see that there is calcification, and usually in these very young infants, I like to do a scleral tunnel. So that is the reflection of the conjunctiva, very mild cautery so that you don't really coagulate those scleral fibers too much. A short tunnel. And there are a lot of challenges. Access is limited. You have to use a special speculum, IOL power calculation, and also the anesthetist has to be quite good. Here, of course, you can see that there's not much of calcification or fibrosis of the capsule itself. The calcific material is in the center, so I'm able to do a CCC with the forceps. You always use a forceps, and you have to keep pulling it to the center because it's very elastic and has a tendency to run out. Hydro, and I just prolapse the nucleus and the material into the anterior chamber. And here I have to use phaco. Normally I use irrigation aspiration, but because of the dense calcified material, I am using a phaco probe here, and then I just remove the calcified nucleus.
Now 130. Here only. No.
And then I have to do a cortical cleanup with the coaxial IA, and then a PCCCC and a vitrectomy. So again, you can see that there is some amount of fibrosis of the posterior capsule. Put in Helon to maintain the chamber. And you can see that's the fibrotic plaque there. I just push it to one side and make a nick. It's central. Anyway, I'm going to remove that with the PCCC so I don't have to peel it. I put in a little bit of viscoelastic into the burger space to push away the anterior hyaloid. And then I go ahead and then do the PCCCC. You can see that it is actually quite thin, the PC, though it is fibrotic in the center. The mid-periphery is a little thin, and it is not like a normal PC of an infant. But I get a 4 millimeter PCCCC and do a anterior vitrectomy. And then here I am placing the IOL in the bag. This is a Technis 1 lens. I calculate the lens power by the rule of 7. So here I'm aiming to do make the child almost 7.5 diopters hyperopic. Place the lens in the bag, and after that I'm doing a capture. So you can see the PCCCC. I put the trailing haptic into the capsular bag, and that's the capture, optic capture, for improved stability and centration. And once that is done, you can just aspirate the viscoelastic, and always suture. In these infants, the wound will not be stable, so even though it's a short scleral tunnel, I suture. And that's one eye. I did a bilateral surgery. This is the second eye. You can see that there is synechiae, and also there is calcific material which has prolapsed through and projecting into the anterior chamber. So this is the tunnel. I make a scleral tunnel, short scleral tunnel. And I have to do a synechotomy here. After entry, I put in trypan blue to stain the capsule. You can see the pupil is also small. There is synechiae, and there is a lot of capsular fibrosis and calcification. You can see that the calcific material is prolapsed through into the anterior chamber. It's very fibrotic. I tried to make a nick and use the forceps, but you can see that there's a lot of stress on the zonule, so it is not budging. It's very fibrotic. The whole capsule is fibrosed. So I go in with a forceps. This is a MST forceps, which are very fine, and it's a curved forceps. So I'm actually making the capsulotomy with the forceps. It's very similar to the case that Dr. Suhas showed. So after I make a nick, again I attempt whether I can tear it, but you can see that it is fibrotic even in the periphery. So again I make a nick on the opposite side with the 26 gauge needle, and then I'm using the scissor to make the capsulotomy. Such very fibrotic capsules and calcified capsules you cannot cut with the vitrector also. Even with the vitrector it's very difficult. So the scissor is the best option to actually make the capsulotomy. And again I'm going through the side port, and you can see that is almost done there. A curved scissor is very beneficial because you can it's easy. If you have a straight scissor, it becomes difficult. So that's the completion of the capsulotomy, and then I remove that fibrous plaque, calcified plaque. This is the hydro, and then the material prolapses. It is, you can see it's fairly soft, so I use the IA probe to remove the nuclear material and the cortex. So here again, entitled carbon dioxide monitoring is very important, and I like to keep the EtCO2 below 27. You can see the poster capsule also is thin and fibrotic. So again it's a challenge here. I just make a nick, put in Helon into the sodium hyaluronate into the patella fossa there, the burger space, and then this is the PCCCC. You can see that it's very thin, and it is not like the usual poster capsule of infants. And in some areas actually I see a double membrane because of the fibrosis, but I am able to complete the PCCCC, and that's the vitrectomy, anterior vitrectomy, which is done to remove the vitreous scaffold. And I'm placing the lens in the capsular bag. Again, you have to be very careful when you place the lens in the capsular bag, and you should see that it goes into the bag and not in the sulcus, otherwise you can have a lot of inflammation. This is a 3-month infant. Many pediatric ophthalmologists are not for putting a IOL in infants less than 1 year. Usually they do not recommend, but we see that the amblyopia reversal is better if you put an IOL, because the visual rehabilitation is not very easy in infants, either with glasses or contact lenses. This is the end of the procedure, and I was able to manage this case very successfully. I just wanted to share it with you. Thank you very much.